All right, I guess we'll get started. Good evening, everybody. My name is John Powers. I'm a senior medical scientist. I work for Leidos Biomedical Research as a contractor here at NIH in the Division of Clinical Research in the Collaborative Clinical Research Branch. So I was asked today, I think this year, this is the first talk for this start off of this Introductions to Principles and Practice of Clinical Research. I can tell because there's more people in the seats than there usually are by the time I come around to give this talk. So what I'd like to do today is talk to you about one of the basic things about any kind of research, and that is how do you choose a research question, and then how that has implications for doing efficient clinical trials. As somebody who reviews research for a living, before I came and did work, I've been working here at NIH for the last 8 years. Before that, I worked almost a decade at the U.S. Food and Drug Administration. So I spent a good amount of time both participating in doing research, but also reviewing research when I was at FDA. And one of the things that becomes very clear is that if you can't understand what someone's research question is, everything else falls apart after that. So we'll go through some of the issues on how to actually choose a research question and the thought process to go through with that, and then how that in turn links to some of the questions that you might want to address while you're developing your research study. Much of what I'm going to talk about today is going to be expanded upon greatly by the rest of the speakers throughout this course. So don't think like you have to scribble down everything, because I'm just going to touch upon some of these things, which we will hear about in greater detail later. Since this is the first talk, I think, as I said, choosing a research question is a first step in research endeavors. We'll talk about types of research questions and the process of working from one question to the next. And that is oftentimes what people will try to do is ask too many questions within a research protocol instead of trying to address this in a stepwise manner of I'm going to do this study first. If I get a yes or no answer, then I'm going to go to the next thing, which is going to lead me to the next thing. And there's the old adage in research that good research probably asks more questions than it answers, because as you learn one thing, it leads to the next question that you build upon. And then we'll talk about, again, the choice of research question and how that has implications for the design of studies, both the choice of the kind of design and issues related to how many participants you need in the research, otherwise referred to as sample size, and how you can most efficiently use resources to get those studies done. So since we're just getting started, it probably is a good thing to actually define what clinical research really is, since this is a course about clinical research. So, and I wanted to actually explain this in terms of what it isn't as well. And that is that oftentimes people get confused between what folks do in clinical practice of medicine versus what's done in clinical research. This became such an important issue that in the 1970s, Congress passed the National Research Act based on some pretty horrific things that had happened in clinical research to research participants, and came out with what was called the Belmont Report that related to ethics in experiments in which humans are involved as participants, and that Belmont Report came out in 1979. The very first section of the Belmont Report clearly explains what they call the boundaries between research and practice. Clinical research, and these are the words directly out of the Belmont Report, designates an activity designed to test a hypothesis and to permit conclusions and thereby develop or contribute to generalizable knowledge, which is expressed in theories, principles, and statements of relationships. So essentially, we're studying groups of participants trying to come up with some general statements. On the other hand, clinical practice is when interventions are designed solely to enhance the well-being of an individual patient or client, and then have a reasonable expectation of success. So that may mean you think that an intervention is going to be helpful in an individual person. That doesn't mean that you're actually testing a hypothesis in groups of people, and it also doesn't mean it's going to work. So, for instance, we're in the midst of the Ebola epidemic now. The fact that an individual physician may decide to try some intervention in one patient is not the same as doing a research protocol that's going to try to evaluate whether a given treatment is effective against treating Ebola disease in groups of people. Difference between research and practice. And again, the reason why the Belmont Report makes this distinction is that oftentimes people get these things very mixed up. And I'm sure you'll get lectures later on this has implications for the ethics of clinical research as well. If a study is designed in such a way that it's so flawed that it can't contribute to generalizable knowledge, it's unethical to even do the study from the beginning. The reason for that is that it puts patients at risk of harm. And harm doesn't necessarily mean they're going to die or experience some physical damage. And the Belmont report goes on to say that even if it's a minor inconvenience, you cannot expose research participants to that if the study is not designed in a way that the knowledge is going to benefit anybody. And if the study is so poorly designed, then it can't benefit anybody. Of course, we tend to rationalize this and say, oh, well, we'll learn something after the fact. But in fact, this is actually done a priori. Not after the study is over. It's done before the single person gets enrolled into the study in terms of evaluating its scientific validity. The term validity often gets confused and used a lot. And validity doesn't mean that you get a bunch of people in a room to agree. I could get everybody in this room and convince them that the moon is made of green cheese, and it still wouldn't be scientifically valid. And so scientific validity, again, is not a nice to have, but a requirement of all research. But validity really has a very simple definition. It's the ability of a study to correctly answer the research question that was posed. And I should have added in there to correctly and precisely answer the research question that was proposed. A lot of the discussions related to the sample size of studies, people always want to have the smallest sample size they can possibly do. Now, from an ethical point of view, that's correct because we don't want to expose more people than we need to experimental interventions. On the flip side of that, if we don't enroll enough people in the study to get a precise enough answer, we won't know whether the intervention actually has more benefits than harms for people. So that gets to the very issue that Bertrand Russell brought up in his History of Western Philosophy. It's not what the man of science believes that distinguishes him, but how and why he believes it. Meaning methodology is important here. The beliefs are tentative, not dogmatic, and they are based on evidence, not on authority or intuition. I took a logic class way back in college, too long ago that I care to remember, and actually one of the logical fallacies was called argumentum ad verecundium. And what it meant was argument from authority. I'm a big shot in my field, you should just believe me. That's not scientific evidence. And we tend to rely on that sometimes, and that's why it says not based on authority. The other thing is there was actually a study done about 20 years ago which showed that the average half-life of a scientific fact is about 7 years. That we often learn new information that disproves things that we previously thought were accurate or correct. And so that's why we can't be dogmatic about this. And in fact, skepticism is actually a part of science. And that we should always be questioning on what we see and whether or not what we believed before was actually correct. There's this talk I give to medical students where I actually show a picture of a Grecian urn where somebody is being bled. Bleeding people was the treatment for many diseases. That urn was from about 2000 BC. In 1799, George Washington was actually bled when he was dying from what was maybe epiglottitis, some kind of throat infection that actually killed him. And his doctor, after the fact, said, well, maybe we actually hastened his death by bleeding him too much. It wasn't until 1835 that Pierre Louis in Paris did a study where he compared bleeding people to not bleeding people in pneumonia, showed that bleeding increased mortality compared to decreasing it, which we know why now, because you actually need to increase somebody's blood volume, not decrease it when they're septic. And actually, Pierre Louis was roundly criticized by the experts of his day and said, well, the problem was you didn't take enough blood from people. So when we're choosing research questions, there's really 4 steps to think about as you're going through this. One is to find a general research topic or idea that interests you, then focus down that question, develop a hypothesis or what description it is that you're actually going to describe, and then finally to come up with specific aims or objectives related to your study. And this is a really useful thought process to go through as you try to narrow down getting to a specific question to answer. So let's go through these one at a time. How do we pick a general research topic or idea? Well, these ideas actually come from real-life experiences. So those of you that may actually care for patients, may actually see things in clinical practice, or have questions asked to you that patients often themselves will pose. For instance, somebody say, well, what do I actually have? Well, that's a diagnostic question, trying to figure out what people actually have and how do you make a diagnosis. Let's just take Ebola again. A lot of discussion about whether we're going to measure people's body temperatures in the airport. Is that an accurate diagnostic way to pick out people who have Ebola versus people who don't? And you actually need research information to actually tell you whether it is. People may be interested in prognosis. Once they know what they have, they say, hey doc, how bad is it? What's going to happen to me? If we're talking about especially, boy, this is relative to Ebola, isn't it? Can I give it to my family? If we're talking about contagious diseases, how contagious is it? I was talking with a friend of mine the other day about this who was asking me questions, and I said, you know, in the general scheme of things, there are far more infectious disease things that are contagious than Ebola. Do you know if you're in an unvaccinated group of people with measles, 99% of people in that room will catch it. That's just how infectious that actually is, which is why the measles vaccine was such an important advance. People may want to know, how did I get this? What things actually result in etiology? And then when it actually comes to either treating or preventing things, they're going to ask me, is this stuff going to help me? And inherent in that is it going to hurt me more than help me? So people want to know the side effects. It's funny, when my mom watches these commercials about new drugs on television and they go through the laundry list of adverse effects, she always says, well, I'm never going to take that stuff. Because after she hears the whole litany of things, she thinks to herself, that's not going to, on balance, be something I want to put up with. So most of the time when we talk about research, we tend here to talk about biological questions. But in fact, it can focus on other areas that relate to people's behavior, environmental factors, etc. For instance, studies that look at why do people come to the doctor for disease X? What behaviors influence the outcome in disease Y? People are not mice in a cage. Various things impact on whether they get better or not. For instance, if you compare people who adhere to taking medication to people who don't, people who adhere to medication, even if you're giving them both groups a placebo, people who adhere to their medication have better outcomes than people who don't. There's something about those folks and the way they live their lives or behave that actually results in better outcomes for them, even if they're not taking an active medication. So those are the same kind of behavioral questions that you can answer. So the other thing is that oftentimes when we're getting ready to do a research study, we find out that we don't know all the things we need to know, or we don't have the tools that are necessary to actually answer the question. It is very tempting to skip over this kind of tool development and go right to the big questions that we're interested in. But what happens is it's kind of like building a house that has no foundation. So I was always disappointed when I was a kid. You'd go to the beach, you'd build this beautiful sandcastle, you know, with 3 levels and a staircase and the whole bit, and you'd come back the next morning and the tides washed it all out. So I actually just built a house recently. About 2 years ago we moved into it, and I actually thought the pouring of the foundation was just amazing. So they come by with these big styrofoam molds, and inside of it they put all these steel rebars, and then they pour all this cement in there, and you say, wow, this thing could survive a tsunami. The rest of the house is all just sticks on top, but the foundation, boy, that's going to stay for a long time. And so developing the tools to actually do a study is the foundation of your study, and oftentimes that information isn't there. And for instance, one of the talks I think you're going to hear next about is patient-centered outcome assessments. Oftentimes what we look at in clinical research studies are biological outcomes. We have the ability to change this laboratory test, when in fact what patients are most interested in is how does it affect their lives? Does it make patients live longer or live better? Okay, I know it changes this lab test, but what does that do in terms of the patient? And oftentimes we don't have the tools that are needed to actually do those patient-centered outcomes. The other thing is you actually need to know something about the disease before you're going to study it. So for instance, with Ebola, people have talked about, well, can somebody sitting on an airplane actually catch it? And you've heard various opinions on the news as to whether that's actually the case or not. So you actually have to know something about the disease. And then you need to have valid measures of outcomes in order to first of all be able to measure it and also to describe risk factors for those outcomes. If you say somebody's going to do poorly, you need to have the outcome measured. Now things like all-cause mortality, you don't need anything special to measure that. On the other hand, if you're going to measure something like symptoms, you actually have to have a valid outcome tool to measure a patient's symptoms with a particular disease. And actually I have a book on my shelf at home called The Science of Measurement. And that book, the very first chapter, makes the point that science was only advanced when measurement came into being. In fact, the first things that we ever developed to measure square footage and yardage was actually because people needed to pass on their property to their heirs. And so the actual development of acreage, etc., was based on a need to actually be able to quantify things and then be able to talk about that with other people. So part of science is actually measurement, and that is, if a milliliter to me is not a milliliter to you, if you use a pipette but I'm just eyeballing it in my lab, we'll never be able to compare results. So measurement is an inherent part of science. So some examples of measurement tools would be, for instance, to develop a severity scale, something that takes baseline variables like how old a person is, what comorbidities they might have, what medicine they're on, and actually relate that to outcomes, and developing the outcome measures themselves. For instance, measures of morbidity like patient functional status and symptoms. And this is actually from the Manual of International Statistical Classification of Diseases way back in 1957. And it said classification is fundamental to the quantitative study of any phenomenon. It is recognized as the basis of all scientific generalization and is therefore an essential element in statistical methodology. Uniform definitions and uniform systems of classification are prerequisites in the advancement of scientific knowledge. In the study of illness and death, therefore, a standard classification of disease and injury for statistical purposes is essential. So what people spend an awful lot of time on, and it's appropriate, is upfront developing diagnostic criteria. How do we know a person has disease X? What we have spent less time on over the years is developing outcome measures that actually relate to outcomes of disease X that actually matter to patients. And so you'll hear some more about that during this course as well. So here's a way of actually thinking about the different kinds of questions that you might want to address. So as we said, a lot of questions relate to biology, but you can ask questions related to people's behavior, related to about how people think. So for instance, I'm working on a study now where we're actually looking at the trade-offs that people make when they decide to participate in a research study. So for instance, they say suppose you tell them that we'd like you to enroll in a study that compares drug X to drug Y. And we think drug X isn't going to be better in effectiveness than drug Y, but we think it's going to have fewer adverse effects than drug Y. What people would think about would be things like, okay, how much am I going to trade off for that? Am I going to let this drug be a little less effective if it's going to have fewer side effects? And that depends upon the setting. If the effectiveness means you're going to live longer, you might not be willing to trade off anything for that. You might say, I'll take more side effects as long as I live longer. If it was a symptomatic disease, you might say, well, that's okay. I'll accept a little less effective drug because I don't want to have bad headache, nausea, vomiting, etc. And then there's social and cultural things that relate to how people address disease. Boy, that's certainly something that's prevalent with Ebola right now in terms of where it's occurring and different people's responses to it. And then there's environmental factors as well. So while we talk about biology a lot, there are lots of different kinds of questions that we can ask. And the reason I put it on this kind of a map is because they're all interrelated. They are not just buckets all by themselves. One thing actually relates to the other. So once you're choosing a broad topic, you've got to choose something that's interesting to you. It's a lot of work. And here's the dirty secret. Clinical research is hard. It's a challenging thing to do. When you're evaluating new medical interventions to help people, actually 8 out of 10 things when you stick them in people don't work. Even after they look great in mice, even after they look great in the test tube, you stick it into the complex biological organism that is a human being, and they don't work. Or they work according to the mechanism of action that you thought was going to happen, but then something else happens through some other mechanism that cancels out the benefits, and the stuff actually turns out more harmful than beneficial. The other thing is, like I said, these are not mice in a cage. People go home, they live their own lives, and they're participating in the research as volunteers. So we have to keep that in mind as well. So you have to choose a topic that is timely and relevant. Otherwise, people are going to ask you, so what? Why did you spend all this effort if you didn't ask a question that's even worth answering to begin with? But you also need to choose a topic that is answerable, keeping in mind time and resource constraints in terms of what you're going to be able to do. And actually, there's a book that was written in 1998. I think there's a new version of this that just came out. And by Hulley and Cummings on designing clinical research, and they have this acronym called FINER in terms of choosing research questions. And that is, you need to choose something feasible, interesting, novel, ethical, and relevant. I would caution you, though, that this term feasible is a very fungible term. And I have heard this used on more than several occasions. to where feasibility has been used to trump scientific validity. It's always easier to do a poor study, always. You can enroll fewer people, do sloppy work, that's always easier to do. But again, it's unethical to do a scientifically invalid study. So remember, when you say feasible, we're talking feasible but scientifically valid at the same time. It's also helpful to have a mentor that can help with all these different facets of this project, who's got some experience in the area you want to work in, who can help you actually think through these things in terms of what resources are available to you and to help you design the study. So once you've got a general research topic that you're interested in, you then have to focus down that question. And what this really means is evaluating the medical literature and other sources to evaluate what the current knowledge is in a given research area. But in many areas, what we know is actually less than what is generally believed. And the reviews and guidelines, treatment guidelines, are a place to start, but they actually represent a synthesis of other people's views on the data, and you need to review that data yourself. It turns out, I wrote an editorial about 4 years ago now for a study that actually showed that 50% of what is listed, of the recommendations that are listed in cardiology and infectious disease treatment guidelines, are based on opinions or case series. Half of it is just dudes sitting around a table coming up with their best guess. Only 11% of what was in the guidelines was based on the results of randomized controlled trials. And it's a really interesting experience to be in some of these treatment guideline committees. I remember once I was at a committee where somebody kept saying something that really wasn't based in evidence, and I said, well, are there any studies that actually show that? And the person turned to me and said, why are you so stuck on evidence-based medicine? I said, well, I thought you would be too. That's why we're here at this treatment guideline committee, is to actually look at what the evidence actually shows. And if the evidence isn't there, there's a move now among people writing treatment guidelines to actually put a section on research gaps. Sometimes my grandmother used to tell me, smart people know what they don't know, meaning you understand where there's gaps in what we actually know. So for instance, in what I do in infectious diseases, you probably know this already, people get antibiotics for all sorts of things that they don't work for. And in fact, there's an editorial, I think, in the Washington Post today. The gentleman who died of Ebola in Texas was sent home from the emergency room with, you guessed it, antibacterial antibiotics. So, and you like to say that that's a rare occurrence, but it's not. So even if the person had another different type of viral infection, antibacterial drugs don't cure viral infections. So, but you go out and you actually look at what happens, and about 50% of people who get antibiotics get them inappropriately, because we believe they work in that setting. So, and that gets us to this. John Ioannidis from Stanford wrote an essay back in 2005 where he mathematically proved that most research is actually false. And so he went through this mathematical modeling, and he said, moreover, for many current scientific fields, claimed research findings may often be simply accurate measures of prevailing biases. And if you read this essay, what he goes through saying is that the studies were designed to get the answer that folks wanted from the beginning. And they started off with a presumption that in fact wasn't true to start with. And so what you end up with is, if you have an if-then statement, if the if part of the statement is wrong, the then statement is going to be for sure inaccurate and wrong. So this gets to the issue of actually not just looking at what people believe to be true. I was actually talking to somebody last year about, I did a review in 2008 of all of the data on the earliest uses of sulfa drugs and penicillin in the 1930s and the 1940s. Now, people would lead you to believe that if we keep talking about antibiotic resistance and the return to the pre-antibiotic era, but what people don't know is that in the pre-antibiotic era, about 7 out of 10 people with pneumonia got better on absolutely nothing. So we think about this as a completely fatal disease, when in fact in young healthy people the survival rate for pneumonia is about 95% on no antibiotics at all. In older, sicker people who have bacteria in their bloodstream, the mortality without antibiotics was about 80%. So it depends who you are. But again, if I was going to go out and do a study in young healthy people and assumed that the success rate was 0 in people who didn't get antibiotics, I'd be wrong, because that's just a prevailing bias. So that gets to this issue of what do we know already, or the knowledge gap. And so that relates to, again, what research question have you started off with? For instance, how do you define the problem that you want to study? What are its clinical features, its signs, its symptoms, and its laboratory values? What do we know about diagnosing it? Is there information on actually how to separate it out? And in fact, you can't blame physicians for their overuse of antibiotics in viral infections, because we have actually very few rapid diagnostics in infectious diseases that allow physicians to separate out who has an infection from no infection, who has a viral infection versus a bacterial infection. So a lot of work to be done in the diagnostic area there. How large is the problem? Are you looking for a needle in a haystack? Is this a disease that occurs in 1 out of every million people, and you're not going to be able to find it even if you look for it? Even if it is a rare problem, what's the impact of the problem? So let's take Ebola as an example again. This can, even though only a few people in the United States have actually been diagnosed with this, the impact has been huge, right? You hear this on the news all the time. We've got somebody here at NIH right now who's in a special unit on this. And the other way to measure impact is not just in resource utilization, but what's the attributable morbidity and mortality. And again, like I said, this is often assumed. It actually is very helpful to go back and actually look at this. In what I do in infectious diseases, we often assume that rabies was a universally fatal disease. And back in 2003, a 15-year-old girl walked out of the hospital completely fine after she had rabies. Now, the doctors did all sorts of stuff to her while she was in the hospital, including putting her in a drug-induced coma, and they then published that what you should do in everybody with rabies is put them into a drug-induced coma. Now, do we know that from one person? Not really. So the CDC then goes down to Peru and does blood tests on all these people that live around bats in the caves, and guess what they find? Loads of people have antibodies to rabies and didn't get sick. So what we thought was a universally fatal disease turns out not to be when we get more information. So, and then what are the risk factors for getting a problem? And risk factors are not necessarily causal. They're just things that are sort of markers for people getting sick. And those are things that are important too, because if they're modifiable risk factors, perhaps we can do something about people getting the disease. Once you get sick, what's the prognosis of the problem? Can we modify that prognosis independent of treatment? Are there things that impact outcomes? So for instance, I said if in the pre-antibiotic era, if you were older to begin with, you had a worse outcome with pneumonia, even if you had the same organism and looked just like the other guy. That age is a prognostic indicator. What interventions can mitigate the problems? And interventions can include not just drugs, but also certain behaviors. Are there things that we can do? And oftentimes, for instance, in the obesity epidemic, we like to talk about drugs when, in fact, diet and exercise are two things that can be very helpful. What factors are effect modifiers of treatment? An effect modifier is something that makes an intervention work better or work worse. And are there things that actually make things work better? So for instance, if we look at when I was doing this review on penicillin for pneumonia in the 1930s, the ventilator was not invented until the 1950s. So the ventilator itself and ICU care can also have an impact on outcomes independent of whether you get an antibiotic. So how relevant that data from the 1930s is now could be mitigated by things like ICUs and ventilator care. And then how do interventions compare to each other? This is a huge area of research now in what's called comparative effectiveness research. That is, if there's 12 different drugs approved for skin infections, antibiotics, how do they stack up against each other? And this is becoming more and more of an issue as we spend more and more on healthcare. People want to know, why should we spend money on something new if the something new isn't something better in some way? And so people are really looking into this issue of comparative effectiveness. So that gets us to this basic thing. Daniel Boorstin was the head of the Library of Congress for a long, long time, and he said the greatest obstacle to discovery is not ignorance, it's the illusion of knowledge. Beware of any statement that starts out, but everybody knows, insert whatever you want to say here. Because you can't make those assumptions that everybody knows until you actually go out and you actually find the evidence in an unbiased way. So this also gets to the what do we know already? What do we know about previous questions that have been asked? I actually teach this course up at Harvard, and 2 years ago one of the students walked up to me and said that he had done this study which actually looked at prophylactic antibiotics before people went to cardiac surgery. There was really very few studies on this, and when he tried to get it published, he said he kept getting rejected from the journals and said, we know this already, even though we really didn't know it already. And so, unfortunately, he was in this idea of, people think they know what they don't know. And that's this, again, this argument from authority. The other question is, what's the quality of the data? So, when I was a fellow, the guy who ran our fellowship program, at one point I remember him saying to me, a big pile of garbage just smells worse than a smaller pile of garbage. So the fact that you have a bunch of little poorly done studies that all give you the same answer may mean you just have a bunch of poorly done studies, and piling them all together doesn't make that into a valid answer. So sometimes the quality of the evidence is poor. Having lots of poor quality data doesn't miraculously turn it into high quality data. Sometimes there is the issue of there's high quality data, but the number of participants in the studies was just too small. That's the theory behind meta-analysis, of putting them together. But doing a meta-analysis on poor quality studies, say that have 50% of people who enrolled in the study missing at the end of the study, that doesn't help you very much. So has the evidence been independently confirmed? A couple of years ago, when my son was in 4th grade, we went to his back-to-school night, and hanging on the wall was this thing that said, "The scientific method." The scientific method has 4 steps. You make an observation, you develop a hypothesis, you test your hypothesis in experiment, and number 4, you confirm it through repeated experimentation. Now, we get this in the lab all the time, right? Nobody does a study in one mouse, calls it a day, and runs out and publishes it, right? We repeat the experiment to confirm it. When we go to doing it in people, we often try to push that by the wayside and say, oh, we have to get this out to people right away because it's so good. Well, that sort of begs the question of, how do you know it's so good if you actually haven't studied it appropriately? Is the evidence consistent across different populations? Are there certain people in who react differently to the intervention? And is that difference even biologically plausible? And then the other thing is that even if we know something, quote unquote, works, how do we know it works optimally in terms of dose, duration, combined with other interventions, etc.? So after you go through that, so what I just spent was 5 slides sort of going through the what do we know already. So you can tell that is a big task to try to actually go through what's actually out there and what do we really know before you actually get started on your study. And that takes a while to do. Once I actually took when I was at FDA, I took this excellent course on medical writing. And they had a timeline of how you write a medical article. And it actually said you spend 25% of the time figuring out what you're going to write about, 25% collating the information, and 25% editing it. So you actually only spent 25% of the time doing the actual writing. And I always thought that's what research is like. You may actually spend only 25% of the time actually doing the study, but you spend an awful lot more time doing the planning and the analyzing as well. And so it's the same way here. So after you evaluate what is known, you've got this big puzzle like we've got up here. You cannot study the whole puzzle. You have to pick one piece of it and decide what it is that you're going to answer there. So, and then how does your research fit into an overall plan? So for instance, if you say, I'm going to work on diagnosis of disease X, once I have a diagnosis, then I can actually go out and use that diagnostic tool to actually look at risk factors for developing that. And you can go to the next question and the next question. So you actually don't want to just think about your single study, but how your single study actually leads to the next question. And it's the most helpful kinds of studies are the ones that you can actually say, if I get a yes answer to this, I'm going to do X. If I get a no answer, I'm going to do Y. I often tell the fellows here, if you're going to order a diagnostic test on a patient, and if the test is positive, you do X, and if the test is negative, you're still going to do X, then don't do the test. And the same thing goes for research. If you're going to do the same thing regardless of the results of the study, then you've got to question whether it's actually worth doing. But a single study can't possibly answer all the questions about a topic, and the second biggest mistake after not having a clear research question is trying to shove every question you can think of into a single study. So it's kind of like having a ship, and if you overload the ship, it's going to sink. So you really have to focus on the research questions that you can possibly answer within the given resources of a single study. And again, how does your research fit into an overall model or theory of the problem? So the next thing gets to this feasibility. What kinds of information or resources do you need to answer the question? And the way to think about this is sort of this PEO mnemonic, and that is population, exposures, and outcome. The population is who are you actually going to look at in your study? And if this is a comparative study, then we're talking about both a test and a control group. So if we want to look at, say, people that have neurologic deficits in HIV, we would want to compare them to a group of patients, people that don't have HIV, as a comparison group. And the exposure is what is it that we're going to be looking at that is done to people, and the outcomes is what we're actually going to look at in terms of how it impacts their life. What kinds of information do you already have available? Is this the kind of thing where you can look through hospital records that already exist to get some information, or are you going to need to go out and study people de novo? What resources are needed to obtain that data? Sometimes the data already exists, but you can't get access to it because of where it might actually be, and therefore is the access to the resources available. And again, feasibility doesn't mean using invalid scientific methods because, well, that's the best we could do. So if the best you can do isn't scientifically valid, then you need to go back to the drawing board and come up with a better question that actually is something that you could do. So once we've focused down that question, we've looked at what's available out there, we've looked at the knowledge gaps, and now we've come up with an interesting question that has not been answered and that's going to fit into the big picture of that research area. Now we finally get to the developing a hypothesis or a description. A hypothesis is a statement about what the investigator believes to be true about nature and the relationships of two or more variables to each other. So hypotheses technically always entail some kind of comparison. But not all research entails a comparison. So for instance, suppose I just wanted to do a study here in the NIH Clinical Center and I wanted to see how many patients with breast cancer get admitted to this hospital in a year. That's not a comparison. That's just a description. And so in that setting, I don't really have a hypothesis per se. I'm just going to describe what was actually measured. On the other hand, if I wanted to compare the number of people admitted to this hospital with breast cancer to suburban hospital across the street, now I'm making a comparison, and I might have a hypothesis that, you know what, this is a specialized hospital. I bet you we enroll more patients with breast cancer or more people with later stages of breast cancer than they do across the street. That's a hypothesis because it has a comparison. The other thing, so that differentiates descriptive from analytical research. Descriptive research is often a good place to start because if you can't describe the disease or the problem that you're going to do first, you certainly can't compare it to something else. But analytical research entails some comparison. The mistake people often make is they start out doing a descriptive study and they just can't help themselves. They got to start doing comparisons within it, right? So you look at the number of people in the clinical center who have breast cancer, and then you start looking at, well, how many people were over 50 and how many people were under 50, and let's compare those two. The problem that happens in that kind of research is you've actually collected the data, and now your hypothesis is coming after you actually did the study. So there is a serial nature to this. Hypothesis comes first, actual analysis comes second. If you do the analysis first and then the hypothesis comes second, you often find things that are false because you're actually letting the data drive your hypothesis rather than the other way around. Hypotheses don't come out of the air. For instance, I said, well, I think we're going to see more later stage breast cancer in this hospital. Why do I think that? I think that because this is even more than a tertiary, it's a quaternary care hospital where many people have already been to another hospital before they come to NIH, which is not always the case with a community hospital where people may come in and seek primary care. So I have a reason for why I had the hypothesis. So when I was working at FDA, I gave a talk about post hoc subgroup analyses. And that is after the study is over, people then dredge through all the data and come up with something they didn't expect they would find in the first place. And one FDA scientist raised his hand and said, what's wrong with that? We find lots of stuff we don't expect to find in clinical trials. And I said, yeah, most of it's wrong. And the reason most of it's wrong is because a hypothesis doesn't get pulled out of the air. The hypothesis starts off with preclinical, clinical data, test tube data, animal studies, and then you develop a hypothesis of what you expect is going to happen in human beings. That's why most of the time when you find something you didn't expect to find, it's because it really wasn't there to begin with in the first place. And that's the difference between associations and causation. Association is just two variables that go together. The best way I ever heard describe an association was the farmer who saw the dog chasing a chicken across the yard, and he said just because the dog was following the chicken doesn't mean the chicken caused the dog. So the fact that two things are going together doesn't mean that one causes the other. The other thing to think about is the difference between qualitative and quantitative research. So suppose you were going to do a survey that you wanted to look at people's attitudes about being admitted to the hospital. So for instance, previous research shows that when people have an exacerbation of the symptoms of their chronic obstructive pulmonary disease, about 70% of the time they stay home. They don't come in to see the doctor. And you may say, I wonder why that is. Why is it that people don't come in? So a qualitative study could be an interview of people to just describe what people tell you about their attitudes about coming into the hospital when they get sick. So there's no quantitation built into that. On the other hand, if you wanted to compare the number of people in Texas who decide to stay home when they have a COPD exacerbation versus the number of people in Maryland, now you've got some quantitative assessment. There's a numerical value that goes along with that. Oftentimes, qualitative research is very, very useful for developing the hypotheses that you then want to test in a quantitative research study. So there's a couple of things that are very different about qualitative and quantitative research. In qualitative research, the aim is a completely detailed description. So what you get from that is words, not numbers. On the other hand, in a quantitative study, the aim is to classify the features and count them. So there's a numerical value that goes along with this. In a qualitative study, you're developing observations for further testing. Remember, what's the first step in the scientific method? Making observations. On the other hand, in quantitative research, you've already made those observations, developed a hypothesis, and now you're constructing statistical models to explain those observations. In a qualitative study, you only know roughly in advance what you're looking for. You don't know what people's attitudes are going to be about being hospitalized. On the other hand, in a quantitative study, you're clearly stating in advance what you're going to look for. The qualitative research is often done in the earliest phases of a research project, whereas quantitative comes later. And the design of a qualitative study often emerges as you learn more. So, for instance, you interview the first 5 patients, they tell you things you didn't think about, and you incorporate those questions into future interviews. And that's fine, because here you are hypothesis generating at this point. On the other hand, all the aspects are carefully designed before data collection in a quantitative study. And the research instrument is actually the researcher in qualitative research, the person who's, say, doing the interviews, whereas a researcher uses tools like questionnaires or equipment to collect numerical data in a quantitative study. The reason I bring this up is that oftentimes people could find very useful qualitative information before they do a quantitative study and they skip that step. And other times also people feel that they will not get something published if they do the qualitative research first. So, for instance, we did a study here last year at the clinical center where we wanted to evaluate what symptoms people have when they have a fever. So, for instance, it is often said that the reason we give antipyretic drugs like Tylenol is to make people's symptoms, make them feel better when they have a fever. Well, guess what nobody's ever done? They never actually evaluated the symptoms of people when they have fever. So how can we be making it better with an antipyretic if we never actually measure them? So the first thing we did was we reviewed records in the hospital, and we actually showed that if a person gets pain medication in this hospital, the nurse goes in and asks the person if they're in pain. They ask them to quantify the pain. They give them pain medication. They come back later and they ask them to re-quantify it to see if there's an effect. What we found when we looked at Tylenol, which was one of the most commonly used drugs in this hospital, is nobody asked the patient a bloody thing. They give them the Tylenol. They come back 4 hours later and stick a thermometer in the air, but they never ask them anything about symptoms. Now, how is Tylenol helping people's symptoms if we never even ask? So what we did was we then interviewed a bunch of people when they had elevated body temperatures. First thing we found out was half the people don't have any symptoms at all, which makes it questionable why we're giving them Tylenol to begin with. But then the second thing is we found out that fever was associated with 16 different symptoms. And we actually published that qualitative research, that when we interviewed people, here's what people told us that they experienced when they had fever. And it wasn't just feeling warm and having chills. It was all sorts of things, such as having funky dreams, not being able to think clearly, which if you don't ask people, you'll never know. And if you never know those things, how are you then going to measure the effect if you're going to randomize people to test the effect of Tylenol versus placebo on affecting symptoms? So that was a great qualitative study as a first step before we went and did something more quantitative. So we already talked about the distinction between descriptive and analytical research, so I'll skip over this. Again, the reason I bring this up is that oftentimes you will be told by people that research needs to be hypothesis-driven. That is very true for quantitative research, but not so much for descriptive and for qualitative research, which also have their place. So you have to be very clear what your questions actually are to begin with. Once you've developed a research question, then you get to this messy map. I won't tell you how long it took me to draw this thing on PowerPoint. And I'm no PowerPoint whiz, so I can't ever lose this slide. But this is a way to actually think about all the different types of study designs that you can choose once you have a research question. So for instance, we already talked about the distinction between analytical and descriptive research, where in analytical there's some comparison between two groups. In analytical research, there is experimental and non-experimental types of design. The distinction between those is in experimental, the investigators decide who gets what. So for instance, in a randomized trial, people by chance are assigned to get the new intervention or to be in a control group of people that don't get the new intervention. In an observational study, that's not done. In an observational study, the investigators just watch what happens in the real world without being the ones to assign who gets what. The problem with this kind of study is that there are often biases in the comparison of who got an intervention versus who didn't. One of the classics is hormone replacement therapy in women. Over 35 observational studies claim to have a benefit of hormone replacement therapy in women, and then when a big NIH-sponsored randomized trial was done, it actually turned out that the intervention was harmful in the types of people who were enrolled into the study. And the reason for that is that the people who took hormone replacement therapy and went to the doctor to get it are not like the people who stayed at home and didn't go to their doctor to get it. They're inherently different people to begin with. In terms of non-experimental studies, there are three different types. There is a cohort study, and in a cohort study, you start off with an exposure and you follow people forwards in time to actually see what happens to them in terms of outcomes. You can actually do this either prospectively, meaning that the data hasn't been collected yet, and you start off with the exposures and follow people forwards in time, or you can do a retrospective cohort study, meaning you're still starting off with the exposure, but the data's already been collected in the medical records, and you're just going to go back and look for that exposure and see what happened to people in time. A case control study is almost always retrospective. And by retrospective, I mean, again, when is the hypothesis determined in relation to when the data is collected? So if the data has already been collected and now you come up with a hypothesis, that's a retrospective study. So in a case control study, you start off with outcomes and look backwards in time to exposure. So for instance, you want to look at people with lung cancer versus no lung cancer and look back and see if more of the people that got lung cancer were smokers. That would be a case control study. A cohort study with, I'm going to start with a whole bunch of people who smoke and a whole bunch of people who don't smoke, and I'm going to follow them forwards in time to see who gets lung cancer. And then the last kind is a cross-sectional study where you would just look at one point in time. I'm going to look at how many smokers have lung cancer and how many non-smokers don't at one particular point. Experimental studies can be divided up into randomized and non-randomized. Randomization is just an amazing tool. It was not even invented until the mid-1940s, and the first randomized trials were in infectious diseases. One was streptomycin for tuberculosis, which actually succeeded and lowered mortality in TB, and the other one was a largely forgotten trial of this drug called Patulin for the common cold, which failed. Still don't have any treatments for the common cold today. And so what randomization is assigning people by chance to which group they're going to go in. And so it uses chance to actually negate chance. So if people are randomly assigned to one group or the other, the idea is that cancels out any differences between the groups. So if you're assigned to group A or group B, the only difference should be in that test or control group is which intervention you receive. So that's the idea behind randomization. In non-randomized studies, there's the same problem as observational studies. Even though you assign people to group X or to group Y, there may be systematic differences between those people because since you know who's going into which group, doctors may say, you know what, I don't really trust that new intervention. I'm not putting my patient in this study. Or they know that what's coming up next is the placebo, and they say, oh, I don't want to give my patient placebo. I'm not going to put them in this study. So you can still bias the results of non-randomized studies. And non-randomized studies can either be concurrent studies where people go to group X or group Y, or external studies, meaning people get assigned to group X, and I'm going to compare them to a group Y sometime in the past. And those are called historically controlled studies. where we'll compare to what happened the problem with these kinds of studies is that on average, people who are in the historical group tend to do worse than the very similar patients in the current group. And the reason for that is oftentimes in the current group we have very strict enrollment criteria which we cannot assure in the historical group. So for instance, suppose we were doing, instead of a randomized trial of streptomycin in 1943, suppose we did an observational study, and in the group that gets streptomycin we make sure that we exclude anybody that's got big cavities on their lungs when they have TB. Well, in the historical group, I may not have that information, and we know that people that have big cavities in their lungs with TB have worse outcomes independent of whatever they get. And therefore, that makes these historical kinds of comparisons really, really tricky and should be reserved for very specific situations. In randomized trials, there's different types of control groups that we can use. One is people get something that looks just like the test intervention, but it's not, and that's a placebo. Or we can give them no treatment at all. Problem is, this cannot be blinded. We know people are getting a treatment or they're not, whereas if we give them a placebo, we can blind who's in what group, and then nobody knows who's getting what and can't bias the outcomes. We can have a dose-response study where people get a higher dose of an intervention compared to a lower dose, or we can compare our test intervention to some older active intervention that was used in the past. Active comparisons can be either what's called superiority studies, where we want to show that the new intervention is better in some way than the older interventions. And in fact, that's the goal of most comparative effectiveness research these days. We want to know if the new stuff is better in some way. But then there's this other type that's called equivalence, or the very poorly named non-inferiority study. And in those cases, what we want to do is rule out that the new intervention isn't some amount worse than the older intervention. Now that doesn't sound like it makes a lot of sense, does it? But in fact, sometimes that's rational if we say, well, we'll allow the new intervention to be as much as 5% less effective because it's going to have fewer side effects or some other benefit for people that is not related to improved effectiveness. So that's the whole types of studies that you can actually do, all in a nutshell, on a single slide. So you have to take your research question and fit it into what kind of study you're going to do. In terms of your hypothesis, the more specific you are, the better. So here's 3 different hypotheses that I'm listing, and they're all different, but they're all about the same thing. So for instance, if I say I'm going to look to see whether antibiotics are effective in otitis media, ear infections in kids, what antibiotic? All antibiotics are not the same. So if I say let's pick one, the most commonly recommended drug in treatment guidelines is amoxicillin. So I'm going to look and see whether amoxicillin is effective in acute otitis media in children. But I'm going to narrow it down to only kids between the ages of 2 and 6 years of age in a very specific population. And in fact, there's a lot of discussion whether antibiotics are effective at all in that particular setting. Or I could be even more specific. I'm going to look at amoxicillin as effective compared to placebo. Effective in what? Effective in reducing pain in children ages 2 to 6 years of age who are having their first episode of an ear infection. Now I'm even more specific. This one is better than this one is better than this one. The more specific you get, the better you are in terms of what your hypothesis actually entails. And that gets you to the last step in selecting a research question, and that's specific aims and objectives. So this gets to, after you're choosing the overall research question, which gives you a why should you bother to do the study, you've got a bunch of other questions in terms of the who, where, when, what, and how. So who are you actually going to study in terms of defining the population? Notice that last hypothesis that I listed had all these things in it, and the other 2 did not. Where are you going to do this? In what setting is this going to be? Is it going to be in an academic medical center? Is it going to be out in the community? When are you going to do this? What's going to be your time frame in which you're going to enroll people? Is it a prospective or a retrospective study? What are you actually going to measure? Is this going to be a study where you start off with an exposure and follow people to outcome? Or is it going to be outcomes looking backwards at exposures? How are you going to do this? What tools do you have to actually measure the things that you need to measure? And again, you need to be as specific as possible. There's a great book written by a guy who's a time management specialist, and the title of his book is Failing to Plan is Planning to Fail. And that is no more true than in research, where you have to really plan all these steps out in advance, which is why it takes a lot of effort in the planning stage, because if you haven't thought about these things, believe me, it'll bite you when you're trying to do the study. And the things you really want to avoid are circular or vague language. The Infectious Disease Society meetings were last Saturday, and there was a presentation. I didn't get to go, but somebody sent me a slide presentation, and no lie, what one of this said was, clinical success in this study is defined as lack of clinical failure. Oh, how enlightening. I have no idea what that actually means. That's circular reasoning, right? So that's not helpful. What I wanted to see was clinical success equals person's pain is gone, person's swelling is gone. You know, what actually, how does that define that? So when you use circular language like that, it doesn't help anybody. Nobody really knows what you actually did. This is one of my favorite TV shows on Saturday morning, This Old House, which my wife always says to me, how come when they saw a piece of wood it comes out perfect, and when you do it, it's always this much off, right? And so my excuse, whether this is true or not, my excuse is they have really cool tools on this show, right? They got the power saw, he's done in like 2 seconds, and I'm out there sawing it by hand, right? So that gets to the issue of you got to have the right tools for the job. So that entails having the resources to do the study, make sure you have the right tools to do the measurements you need to do in the study, just like these guys always do on their TV show. So what are some of the common pitfalls in doing this? So the first thing is letting feasibility issues change your research question to one that's not worth answering, or pushing ahead with a study in a scientifically invalid way so that you answer it, but you've answered it in an invalid way. The second thing is sinking the ship by taking on too many questions and thereby answering none. And so it really does pay to focus your questions. Lack of clarity on the hypothesis and lack of clarity on study design are two other issues. I was recently on a scientific review board where there were 6 groups within the study, and it was very clear who went into those groups. What wasn't clear is what was being compared to what. Is one group going to be compared to the other 5? Is each one going to be compared to everybody else, in which case we got lines going every which way? And it wasn't at all clear what the actual comparisons were in the study. And then vague specific aims, vague variables about what's going to measure, and unclear measurement properties of the tools that you're actually going to be using to do the study. So now that we know all that stuff, let's just finish up a little bit here. And I'm going to just try to touch upon these things. The last couple of years, this was an entirely separate talk, and I was sort of asked to put this in at the end after the focusing on research questions. Let me stop at this point, though, and see if there's any questions about this issue of how you select a research question. So everybody's hypoglycemic and too close to dinner. There's one. So the question is, should the hypothesis always be based on evidence? Yes. That evidence could be stuff you've generated yourself. It could be stuff you've gone and looked up in the medical literature. But it should be based on something that you know already. If that evidence doesn't exist, then you're back at the earlier stages of maybe you have to do the qualitative research or the descriptive research to actually get that evidence before you actually go ahead and do your study. And sometimes it's as simple as, I remember I reviewed one study that was studying a drug that had been actually out there and used for some other things. And I asked one simple question to the scientific review board. Where'd you come up with the dose for this study, since this is a completely new use? Dead silence. Well, we kind of picked a dose that was halfway in between the other 2 uses. That's not evidence. That's a guess, right? So you can't do that to people. You actually got to have some idea of which doses. And in fact, a better way to do that kind of study is perhaps then make the study a study with several doses that'll actually evaluate that and answer that question before you go forward. So yes, a hypothesis has got to have something that you're basing it on. And usually people have that in the back of their head, they just don't explicitly state it. And that's the thing that you really have to make sure you do. Any other questions? Oh, sorry. The light's shining in my eye here, so I can't see. So the question is, how do you decide to choose whether it's a randomized or a non-randomized study? So really, if you can do a randomized study, it's always better because it takes care of the issue of selection bias. If you don't do a randomized study, you always have the question that perhaps the test and the control group are not comparable to each other at baseline. There are some situations, if you were talking about a disease that was highly or universally fatal, and you knew this from the historical literature, those are the settings in which you could do a non-randomized historical controlled study. But those things are very few and far between that actually meet that kind of criteria. So for the most part, if you are going to have a comparison, a concurrent comparison between a test and the control group, it always makes much more sense to try to do that through randomization. And randomization itself is not the problem. Randomization can actually be done by taking a coin out of your pocket and flipping it. Any random process that assigns people will work. Right now we use fancy computerized tables to do it, but literally you can take a coin out of your pocket and flip it. The key is you can't know what's coming up next, and neither can the investigators. So if you come up with a randomized table of numbers and then you post it on the door of the hospital so everybody knows what's coming up next, that study's not really random, because then people can jury rig who goes into the study. So randomization is always preferable if you're evaluating a new intervention, except in certain settings. That's right. So you actually outlined one of the problems. So if you want to look into this more, there's a website called the International Conference on Harmonization, or ICH. It's www.ich.org. On that they have various guidances, guidelines, and they divide them up into efficacy and safety questions, etc. If you go on there, there's a guidance called E10, Efficacy-10. In there, it's called Statistical Concepts in Selecting a Control Group, and it's got an excellent discussion of all the different types of controls, and it outlines the pros and cons of historical controls. One of the things it actually says is that there's a time problem with historical controls. If you compare what we do to patients now to patients 20 years ago, medical care itself may have changed in that period of time, and that makes your comparison invalid. And so you can actually do a concurrent external control, meaning it's not randomized and it's not back in time, it's done now. So that would be if I was going to compare what we do here to what we do to Suburban Hospital in a non-randomized study. That would be a concurrent external control, but it's still got the same problems in terms of comparability of the subjects. So what ICH-E10 actually outlines is how it has to be a very specific type of disease with a very fixed time course, with a very uniform outcomes that are not affected by patient variables. Yep. Sure. Mm-hmm. So that's right, but those are just descriptive. But in fact, that's not how you actually report qualitative research. That's one of the trickiest things about it. We just can't help ourselves. The question was, isn't there always a quantitative aspect even to qualitative research? So you're right. What happens is people will say, we just did this for influenza. We're developing a symptom scale for influenza. We interviewed 60 people that had documented influenza. And then we published the paper and we go, X% of people said they had cough. But in fact, that's actually not very relevant. The way to do those studies is you keep interviewing people until you reach what's called saturation. And that is, we kept interviewing people until, and each time we would hear a new symptom, we would put it listed. Then at the next people, we'd ask them about those symptoms. And pretty soon we got to the point where we had captured all the symptoms and everybody was telling us the same thing. So in fact, that's really the way that we're doing it. But you're absolutely right. We describe it because it's just in our brains that we have to put a proportion of how many people actually said it. But that may not be the best way to do it, because maybe the thing that people say the least is actually very important as a part of that disease. So that's why we do it, but really qualitative is very distinct than quantitative. But you're right, people do that all the time. Any other questions about that? Okay. Good. Not everybody's asleep. So the last thing I wanted to finish up was just to talk about how do we take those principles and do trials more efficiently. So first of all, we got to define what a trial is and what efficiency means. So a clinical trial is a controlled prospective study enrolling human subjects that's often used to evaluate the effectiveness and or harms of interventions in treatment, prevention, or diagnosis of disease. So we're not talking about descriptive research now. We're talking about analytical research where we're comparing to an intervention versus something else in a test and a control group. Efficiency is something completely different. In physics, it's the ratio of useful work to the energy supplied to it. And in fact, in clinical research, it's very much the same thing. In clinical trials, it's getting valid and reliable results or answers to important questions with the least amount of resources. It doesn't mean putting patients at risk through invalid study designs. And lower sample size does not mean less work. It actually means more work, because you actually have to do more planning if you want to have fewer subjects in your study. So in 2001, the Institute of Medicine published an entire 200-page monograph called Small Clinical Trials, Issues and Challenges. Excellent thing if you want, to use this doorstop for some light reading. But it actually points out clinical trials with small numbers of participants must address broad sets of issues that are different from those that must be addressed in trials with large numbers of participants. It is in those circumstances of trials with small sample sizes that approaches to optimization of the study design and data interpretation pose greater challenges. So they were very clear that you're going to need to do extra work to do a smaller study. So first of all, they actually talk about what do we mean by large and small anyway? So in what I do, there's a lot of discussion about getting more antibiotics approved through the FDA so we can have options because of antibiotic resistance. And so people talk about, well, to do that we need to do smaller studies. Well, it turns out that antibiotic studies are already the smallest studies of any therapeutic area, any. So if you compare infectious disease trials to, say, cardiology, the average infectious disease trial has between 300 and 600 patients, and a cardiology trial has thousands. So what do we mean by small when we're already the smallest? So the Institute of Medicine defined a large trial as one that has an adequate sample size to answer the primary question. So in other words, large enough. And it reminds me when I was a resident, I asked one infectious disease specialist, well, how long do I need to give this drug to the patient? He said, well, long enough to get better and not longer than that. So same thing here. You have to have a study that's large enough to be able to answer the question. A trial with very few participants may still have adequate statistical power, but the thing that actually drives that is really, really effective interventions don't need a big sample size. If the intervention doesn't work, you can have an infinite sample size, and you're not going to show anything meaningful for patients anyway. So there's a balance here between exposing research subjects to potential harm of experimental interventions while obtaining valid answers. So people have actually written a lot about this, and this was published in JAMA in 2002, actually arguing that studies that going into it we know are too small to answer the research question are unethical on their face. And that is that we know that we're not going to get any legitimate answers out of this, so according to what we know from the Belmont report, we shouldn't be doing this. And so people have argued, well, that's okay. These studies can be combined in a meta-analysis later. Well, but that's, again, revisionist thinking. How do we know somebody's going to do a meta-analysis later? How do we know somebody's going to do another bunch of smaller studies? Oh, and by the way, rather than spending the resources on a bunch of small, poorly designed studies, why don't we just do the one big study that would actually answer the question to begin with? So it's kind of weak analysis to say that, well, we'll just rely on some future meta-analysis. You guys are too young to know about the cartoon Popeye, but when I was a kid, there was this sailor named Popeye, and he had a friend called Wimpy. And this guy would always come by and say, I will gladly pay you for a hamburger on Tuesday if you buy it for me today. People always have an excuse as to why we should do something today that will somehow pay for tomorrow. And so this paper actually goes through the illogic of saying, well, it's okay to do invalid studies because we might figure it out later. So they also talk about how a proposed study that cannot answer the question being asked because the necessary sample size cannot be obtained should not be conducted on ethical grounds. That is, it is unacceptable to expose patients or research participants to harms, even inconveniences, if there is no prospect that useful and potentially generalizable information will result from the study. Comes straight from the Belmont report in 1979. Can't do this to people. Can't expose people to stuff if we're not going to get legitimate answers out of the end. And it says the importance of conducting small clinical studies only when there is no alternative cannot be overemphasized, and this committee is not encouraging the use of small clinical trials, but rather providing advice on strategies that should be considered in the design and analysis of small clinical studies. So the reason I bring this up is that in the infectious disease realm, we're kind of talking about making these the standard. And it's actually what they're saying here is, no, these should never be the standard. This is only something that you should do. For instance, one of the examples they give in this monograph is astronauts. How many people actually go into space? Only a handful. There's nothing you can do about that. That's an inherently small sample size. People that get pneumonia, that's not a small sample size. 4 million people a year in the United States get pneumonia. So what happens is small numbers increase variability and leave a whole lot to chance. So I'm going to run through some of these things. While small clinical trials are a last resort, efficient clinical studies are always desirable. We always want to do the most we can with the least amount of resources. And so that really entails thinking about 7 different things. Now, the rest of these things you're going to hear about during the rest of your lectures during this course. I just went through bullet number 1 today, having a clear objective and a clear research question. But you've got things like, if there's a comparison in your study, you need to select the right control group. You need to select the right kinds of people for inclusion in the study. If it's a comparative study, you've got to make sure that the test and the control group are comparable. If that's through randomization, fine. If it's not through randomization, you still have to do it through some other methodology. You need to minimize bias in the study, have well-defined and reliable outcome measures, and preferably ones that are patient-centered, that measure what patients actually want to know about in their lives, and then appropriate statistical analysis. These are all the things you're going to hear about during this course, and I only did this one today. How are you going to start off with the right question to begin with? The last thing I'll finish up with just for a few minutes is, where does sample size come from? Drug companies talk a lot about sample size. And the reason they talk about sample size is not just patient protection, it's money. The more people you have to enroll in a study, the more it's going to cost them, the longer it takes them to do a study, the more it costs them. So they talk an awful lot about sample size all the time. But really, sample size is a scientific issue. It's not like the regulators make them put X amount of people in, or the mean statistician makes them do it. There's actually a science behind this. If you take any variable, let's take the height of the people in this room that has a normal distribution, what you've got is about 2/3 of the data or 95% of the data are within 2 standard deviations of this central mean, and the little 2 tails at the end have 2.5% of the data in them. So 95% of the data is between 1.96 standard deviations, but for you to have a normal curve, you need to have at least 30 points to be able to get started. So we're talking right off the bat, at least 30 participants. Now, in a descriptive study, all we're doing is we're taking this one curve, and by increasing sample size, this curve gets narrower, which means the width of this curve is smaller, and that's variability. So this variability here is what we call precision. So in a descriptive study, your sample size will be based on how precise an answer do you want. For instance, if I flip a coin 10 times and I get 5 heads, it's 50%. But the precision of that is much less than if I flipped a coin 1,000 times and I got 500 heads. It's still 50%, but the precision around that estimate is much better. I learned this in freshman year of college when I was in physics class, and they made you take several measurements of the same variable over and over again and average them out. Right? You know, every measurement is associated with the true value plus some associated error. And the more measurements you take, the more you'll minimize that actual error, as long as you're taking unbiased measurements. If my ruler was screwed up to begin with, it doesn't matter how many measurements I take. I will get greater precision, but I will just be more precisely wrong. So when we're comparing 2 groups, what we're doing is we want to see if these 2 curves are separate from each other by a big enough amount to rule out the play of chance. So what a p-value of 0.05 means is that the mean of this group excludes everything but the little tiny 2.5% tail of the other group. That's what a p-value means. Notice that's a heck of a lot of overlap, right? So we talk about, oh, p-value of 0.05, that was just something somebody, R.A. Fisher picked out in 1920. It's actually a pretty low standard of evidence. It means you're wrong 1 in 20 times, and when I look at that curve, I say, wow, that's actually overlapping a good bit. So what do you do to actually, if you increase sample size? If you increase sample size, what happens is this. Notice the shape of these curves now changes. And notice that little red area is now entirely to the left of the mean of this group. So the blue area is what we call power, or the ability to detect a difference if such a difference exists. Don't worry about that here. You're going to get other lectures on this at this point. I just want you to visualize what's going on with sample size. So the other thing is, notice here that the difference between these two curves didn't change. Remember when I said more effective interventions, you don't need as many participants? If this curve was way over here, now you don't need as many people to be able to actually show that difference. So on the other hand, if this difference is fixed, then what you can do is actually try to narrow these curves. So, and here's another example where if we enroll even more people, now look that these two curves barely overlap at all. This blue area is now 98% of this curve, which means the ability to detect a difference if a difference exists is 98%. So I'm just going to skip ahead because I want to. So this difference between the two curves is called the treatment effect size, and the width of the individual curve is variability. So I'm going to finish up with this particular one because I got to unfortunately drive and catch a train up in Baltimore here and be up there by 7:30. So there are a couple of ways to actually be able to do this. So the ways to actually look at this are actually to try to make those curves narrower. You can't determine whether you can't make an intervention better than it is. You can't make these two curves differ because that's biology. If this drug is 10% better than that drug, that's the way it is. What you can do, though, is you can decrease the width of these curves. And you can do that through several things. The first is what we discussed today. Have a very focused and relevant research question. If you're going to study all sorts of patients with all sorts of stuff, there'll be a whole lot of noise in there that will actually make it harder for you to measure it. The second thing that you can do is you can monkey with the statistics. You can change it and say, oh, p-value of 0.05, that's not for me. I'm going to have a p-value of 0.10. Don't do that. That's not a good idea because what that does is it says you're willing to accept more uncertainty. A p-value of 0.05, like I said, already means that you're wrong 1 in 20 times. If you want to see how often that is, go to clinicaltrials.gov and look at the hundreds of thousands of studies that are on there. If you say 1 in 20 you're wrong, that's a huge chunk of studies that might actually be wrong. If you increase that p-value to 0.1, you're now wrong 1 in every 10 times instead of 1 in every 20. I always joke with the fellows that do clinical care that you want to see how bad 1 in 20 is? Hang a sign on your clinic door that says, I'm wrong 1 in 20 times, and watch the waiting room empty out. So the next thing you can try to do is you can try to make sure that the population is more homogeneous. So in other words, I'm going to do a study in people only over the age of 65. I'm not going to do a study in all sorts of people because that's where I think my intervention has its greatest effect. You can also choose a population in whom the effect size is larger, such as the example I just gave. Make sure that you're optimizing the exposure. For instance, you look at previous studies and say, this dose of drug seems to work better than that dose, therefore I'm going to use that for my study. You can use continuous instead of dichotomous outcome measures. In other words, suppose you want to look at the time that it takes people to get better. So you can look at it in two ways. You can say, I'm going to look at the proportion of the research participants who feel better by day 10, or you can say, I am going to look over those 10 days at the time it takes people to get better. If you look at the time it takes people to get better, you're using all the data points along the way, and therefore that gives you increased ability to detect differences when they exist. And in fact, I'll just show you this example here. If you don't do that. Here's an example of a study that was compared ciprofloxacin to azithromycin in the treatment of cholera. This is 120 hours. Suppose I came back in 10 days. Am I going to see any difference between azithromycin and cipro? No, because that's way out here. So by looking at the time it took people's diarrhea to get better, you were able to detect this big difference between the two interventions. So that's an example of where that actually works. Also, selecting outcome measures that are more relevant. Outcome measures that are based on doctor judgment have a lot of noise in them because different doctors look at different things. So for instance, there are clinical studies in infectious diseases that say the outcome is the doctor's judgment that the patient's signs and symptoms of the infection are improved or resolved. It turns out that different doctors look at different things, and therefore it becomes really messy when you're trying to use that kind of an outcome measure. So it is well worth your while to have a standardized way of evaluating outcomes. And the last thing you can do is to try to narrow those curves by decreasing variability. Use more sensitive and specific measurements for both including people in your study as well as excluding people from your study. Assuring follow-up of all the enrolled subjects. If you want to enroll 50 people in your study and 25 of them don't come back, you got a problem. So, and people don't think about this ahead of time. The time to think about how you're going to get people to come back is before the first person's ever been enrolled in the study. So I remember I raised this question with a fellow once, and they said, oh, well, we don't have to worry about it because, you know, we're NIH. Well, really, it's actually harder to get on this campus than it is to get on most hospitals. And some people won't come back and say, I just don't want to be hassled with this. I don't want to get this frisked up inside one down the other just to get into the building. So you talk about things like paying for cab vouchers, paying for Metro cards, calling people. You want to make it so worth, you want to be such a pest that it's worth their while to come in just to get them to stop you from calling. And then finally, there are types of study designs which you'll hear about during this course. For instance, you may put people on A versus B and then switch people on B to A and on A to B and switch them over. And therefore, you're actually using the patients, they say, as their own control. People are compared across those studies. That only works for diseases that are very stable over time. If it's a disease that goes up and down, that will not work. Or if it's a disease where the interventions, the first intervention affects the second, which is most infections. If I give you an antibiotic, it's going to affect what actually happens to your flora in the second half of the study. So we don't often use these kinds of crossover designs in infectious diseases. So I'm going to stop there because this is going to be stuff you focus on in the rest of the course. What I covered today was just this part about trying to come up with a focused research question. And you're going to hear a lot more about all these other things, but this is sort of a toe in the water for the rest of the course today. Any other questions I can answer at this point? Whatever. Yeah, so the question is, what's the role of data standards? That's exactly part of this, right?